if you're able to get me loud and clear.
Yes.
Yes, we are able to hear you.
Thank you very much. Apologies for...
Yes.
All right, great. Apologies for starting late. We had a bit of internet challenges at the hub, but it has since been corrected. So once more, joining you from the hub, I'm Dr. Matibula Peter. In the hub, I'm joined by our coordinator, Kunda Mwila, and also our IT support. So welcome once more to all the participants joining us from wherever you are. Right, so today we are looking at a very interesting and important topic, that is polio response in Zambia, looking at what has been happening in the region. So it's really an extraordinary echo. So to make today's didactic presentation, we'll be joined by Dr. Musole Chipoya, who will give us this presentation for today. And we'll also be joined by a panel of experts, which will include Dr. Dalila Zachary, Professor Lloyd Mulenga, and also Dr. Sombo Foloshi. Right, so once more, welcome. Just a reminder, colleagues, on echo etiquette, let's remember to keep our mics muted and only speak when you're asked to speak. You can, if you have any questions, you can use the echo provisions provided by raising up your hand. Right, so without wasting much of the time, we'll go straight into the didactic presentation. We don't have a case for today, but there should be a series of cases that will be gone through during the presentation. So we'll basically look at polio in the region and Zambia's polio vaccine response. And in that, we'll review the epidemiology in the region, and also look at an update on Zambia's polio vaccine campaign, and discuss clinical presentation and touch a bit on the management of polio with the help of our panelists that are joining us for today. Right, so I'll hand over to Dr. Musole Chipoya, who will make the didactic presentation for this afternoon. So Dr. Chipoya, over to you. You can introduce yourself and start with the presentation for this afternoon. Thank you. Over to you, Dr. Chipoya.
Thank you. My name is Dr. Musole Chipoya. I'm from the Zambia National Public Health Institute. I'm the surveillance focal person for vaccine preventable diseases in the surveillance cluster. I'll be presenting today on the polio response in Zambia, the history of the Malawi case, and the status quo as at now. We can proceed to the next slide.
All right, so we'll start with a poll question before we proceed with the presentation. Right, so the poll question, all right.
Okay, so do you need me to take us through the poll question?
No, I think it's a wrong poll that was. All right, so Dr. Chipoya, you can go through the poll question.
Okay, so the first question is, globally, which two countries remain endemic for wild polioviruses? So A is Afghanistan and Somalia, B is Malawi and Afghanistan, C, Afghanistan and Pakistan, and then we have Pakistan and Syria for D.
Okay, so it seems the poll question wasn't uploaded, so I think we can go ahead with the presentation. Over to you, Dr. Chipoya.
The poll question is currently showing now, so maybe we can wait and have it.
All right, great. So the poll question has come up. Okay, so we'll just give it a few more minutes. More than 50% of the network has actually responded to the poll. So I'll end it in the next few seconds and share the results. So the majority so far are going for Malawi and Afghanistan, but we'll see as the presentation goes on which two countries still remain endemic for the world polio virus. So allow me to end the poll at this point. We have more than 70% of the network has responded to the poll. So I'll end the poll and share the results. Right, so there you have it. Majority feel B, that is Malawi and Afghanistan, the countries that still remain endemic for the world polio virus. So over to you, Dr. Sole.
Okay, thank you. I believe we can proceed. We'll respond with the answer at the end of this presentation. Okay, so we'll go through the epidemiology. So on the 17th of February, 2022, Malawi declared an outbreak of wild poliovirus type 1. The case was a 3-year-old female child of Lilongwe who had no history of travel outside the country. Laboratory analysis showed that the wild poliovirus isolated was genetically linked to a sequence detected in Sindh province in Pakistan in 2020. In addition, there were 19 nucleotide changes on the virus that was picked in Lilongwe in this year. Okay, we can proceed. So we'll go back into just having a brief discussion on what polio is. So polio is a highly infectious disease which usually affects children under 5 years of age. 1 in 200 infections lead to irreversible paralysis. And among those that are paralyzed, 5 to 10% die with their breathing muscles becoming immobilized. So it paralyzes the breathing muscles. Cases due to wild polioviruses have decreased significantly from 1988 by 99%. From the estimated 350,000 cases then to about 33 cases reported in 2018. So as long as we have children that are still infected with polio, in whatever countries these children may be, we still remain at high risk of having polioviruses or contacting polioviruses in many countries. Okay, next. We can proceed. So what is our surveillance risk? So the African region was declared free of indigenous wild polioviruses in August 2020. The presence of a wild poliovirus in Malawi with 19 nucleotide changes, it signifies a two-year time period of silent transmission, where the area of most recent circulation is not known. A detection of any other cases within the region will result in rescinding of the polio-free status, the wild polio-free status for the African region. So while national level, what we are monitoring is what is called the non-polio AFP rate to help us know whether we have any circulation of polioviruses within the country. So at national level, the AFP surveillance indicators have been optimal. But when we drill down to subnational level, we find that the performance for the non-polio AFP rate is suboptimal, meaning we are not able to actually say for a fact that we do not have poliovirus circulating in our country. Next. So what are the planned activities and what are some of the activities that are ongoing? So firstly, we have a planned campaign response, a vaccination campaign response, which are being called the supplementary immunization activities. These are, for this, we're having 4 rounds. So the first round was in 3 provinces, in Lusaka, Eastern and Muchinga provinces. This was from the 21st to the 24th of March. The second round has started today, and this is a nationwide campaign, and it's taking place from the 25th to the 28th of April, 2022. We'll have 2 other rounds after this, and these 2 rounds will also be a nationwide campaign. In addition to this, we also have enhanced surveillance, which is ongoing. So we'll have active case search for any AFP cases. This is supposed to be done in all hospitals, as well as in all major hospitals, as well as medium and low priority facilities. We target, for this particular one, we target tertiary hospitals because we know that any complicated cases will definitely be referred to the tertiary facilities for further investigation. In addition to this, we're also conducting health worker and community sensitization on AFP and poliomyelitis. The third point is enhancing routine immunization. So this includes both BOPV and IPV immunization. Okay, we'll now go into poll number 2. Our question here is, how many serotypes of polioviruses are there?
All right, so poll number 2 has just been launched. So the question is, how many serotypes of poliovirus are there? Is it A, are there 3? Is it only 1? Is it C2, or are there 5? I'll read the question again. So how many serotypes of poliovirus are there? Is it 3? Is it 1? Is it 2? Or is it indeed 5? Right, so we'll give the network just a minute or so for the network to respond to the poll, and then we'll end the poll and share the results. And then we'll see subsequently with the presentation as we go on, how many serotypes of poliovirus are actually there. So interestingly, so far, the majority is going for 3, which is very good. Right, so a few more seconds before we end the poll and then share the results. Just waiting for at least more than 60% of the network to respond to the poll, and then end the poll and share the result. We have 173 connections, and so far less than 100 have responded to the poll. I encourage the network to respond to the poll before we can end the poll and share the results. Okay, so we have slightly over 50% of the network responding to the poll. So at this point, allow me to end the poll and actually share the results. Okay, so there you have it. I think 60% of the network agree that there are 3 serotypes of poliovirus that are there. Right, so at this point, I'll hand back over to Dr. Chipoya to proceed with the presentation.
Okay, thank you. We can proceed. So surveillance risk, we'll continue with this. So what type of a virus is polio? So polio, this is an RNA virus with 3 serotypes. So we have type 1, type 2, and type 3. Immunity against one serotype does not confer immunity against other serotypes. So we have different vaccines which target the 3 different serotypes. So type 1 and 3 are in the BOPV, and then we have the type 2, which is in the IPV, inactivated poliovirus, whereas the BOPV actually stands for the bivalent oral poliovirus. This is rapidly inactivated by heat, formaldehyde, and ultraviolet light. In addition to these 3 serotypes, we also have, sorry, before we proceed to this next slide, we also have the circulating vaccine-derived polioviruses. These occur in areas with under-immunized children, where we have high numbers of under-immunized children, where the vaccine that is actually provided reverts back to a neurovirulent type, which is able to cause paralysis in children. So that is why we advocate as much as possible to have high vaccination coverages to infer that herd immunity for different populations and ensure that we do not have vaccines reverting back to a neurovirulent type. Next. Okay, so paralytic poliomyelitis, clinical presentation of paralysis. So what type of paralysis are we looking at? We're saying this is an asymmetrical paralysis, and it usually affects one limb. It is flaccid, so the paralysis is floppy, and there's a loss of muscle tone in the affected limb. The paralysis moves from the proximal to a distal end, meaning it starts in the big muscles near the body and moves to the outer parts of the limbs later on. Next. So when should we have a raised clinical suspicion? So this is a video, I hope we can be able to play it, which shows one of the cases, the acute flaccid paralysis cases that were detected in Chiengi. We just wanted to show this and see what kind of cases we'll be investigating for poliomyelitis. Are we able to play the video?
Unfortunately not, so we can proceed with the presentation.
Yeah. Okay, thank you. So the signs and symptoms, what signs and symptoms do we have, and what is the clinical manifestation for these infections? So we can see here that 70% of those infected with polioviruses will not show any symptoms, meaning they'll be asymptomatic for any infection. We'll have 30% who will present with clinical illness, but not paralysis. So in the clinical illness, these will present with flu-like symptoms, mostly fever, headache. There may be upper respiratory tract infections, sore throat, and these usually resolve within a period of three days to a week. Then we have the 1% of the population that will present with paralytic disease. So those are the ones that will now present with acute flaccid paralysis, and those are the ones we hope to pick up and collect samples for to investigate as cases of poliomyelitis. Next. So what is the purpose of polio surveillance? So firstly, we've been talking about AFP, which is acute flaccid paralysis. We want to understand what exactly is acute flaccid paralysis. So acute flaccid paralysis is the sudden onset of paralysis or weakness in any part of the body in a child less than 15 years of age, or in any person of any age in which a clinician deems fit as a paralytic disease that can be where poliomyelitis is suspected. So this is one of the syndromes that we are looking out for that will help us have a high index of suspicion for cases of polio. So AFP surveillance is the gold standard for detecting transmission of polioviruses, because we know that this disease cannot be, a clinical diagnosis cannot be made for this disease. So what are the types of poliovirus surveillance? So we have active surveillance, which is done when we are actually, as clinicians, screening patients and going through, sorry, we're still on the previous presentation, on the previous slide. So we have active surveillance, passive surveillance, and community-based surveillance. Active surveillance is when we as clinicians are actually reviewing these cases as they come through our facilities. Then we have passive surveillance, which is done when we are reviewing the registers of to see the cases that we have had in the health facilities and if we may have missed out any cases. Then we have community-based surveillance, where we're actually able to. Sorry, can we please mute ourselves? Thank you. Then we have community-based surveillance, where we have cases being brought in from the community as cases of acute flaccid paralysis. Next slide. So this is a brief history of poliovirus in Zambia. So the outbreak of circulating vaccine-derived poliovirus in Zambia. So in September 2019, this is the last case that these are the last 2 cases of polio we had in Zambia. We confirmed a case in Chavuma and in Chiengi. The first case in Chiengi was in a 2-year-old male child of Chiengi district in Luapula province. This was a vaccine-derived poliovirus. The case had no history of vaccination since birth. and history revealed paralysis following less than 24 hours of fever. The Chavuma case was a female 2 years old with a history of receiving only one vaccine, which is the zero-dose BOPV, which was given at birth. Okay, we can proceed. So polio diagnosis, how do we make a diagnosis of polio? So we cannot confirm cases of polio using clinical symptoms alone. No blood tests to confirm polio diagnosis, and definite diagnosis is only done when the isolation of poliovirus is conducted in stool specimen. Next. So what are the key steps of AFP surveillance? One, finding and reporting children with acute flaccid paralysis. These could be any cases. As clinicians, we will have various cases that will come into our health facilities. Cases with Guillain-Barré syndrome, cases with transient myelitis, severe malaria presenting with acute flaccid paralysis. As long as we have acute flaccid paralysis in those children, one of the things we should investigate for is collecting samples to rule out the possibility of having polioviruses in these cases. So that is the only way that we will actually be able to rule out polio in these cases. Collecting 2 stool specimens as soon as possible after the onset of paralysis should be done, and testing of specimen in a WHO accredited laboratory to confirm the presence of poliovirus should be done. In Zambia, this lab is actually at the University Teaching Hospital in the virology lab. Next. So this is the AFP surveillance indicators. This is just showing us what we need to report as a country. So we can see the annual expected AFP cases. So for Lusaka province in particular, we're expected to report 31 AFP cases. And like I have said, AFP is not going to be your diagnosis. This is just going to be a syndrome that you find in the many cases that we see in the hospital. So what we need to look out for is the acute flaccid paralysis. And when you see that any child has presented with acute flaccid paralysis, we need to collect specimen from this child and actually rule out the presence of poliovirus in this child's specimen. We can see so far for 2022, Lusaka has only reported 2 AFP cases, but this is where we have all the tertiary hospitals. So whatever complex cases we have already been referred to either UTH, Levy, or Soko for investigation. So as a country, the non-polio AFP rate, since we are in outbreak mode, has now been raised to 4 cases per 100,000 population under 15 years of age. The stool adequacy is currently at 70%. These are some of the indicators we look at to help us assess how adequate these samples are that are going to the lab. So we are working against a target of 80%, but currently we're below that at 70%. The next one here is showing us the percentage of 6 to 59 months old children that have been issued with OPV doses. So only 61% have received 3+ doses so far, which is below 80% or at least 85%, which is what we hope to target. Next. Okay, next we're going into a poll of questions.
All right, so we'll briefly pause for a poll of questions. I think some of the material has actually been presented, so just checking if learning has actually taken place. So the first one is poll question number 3, which reads, there are 3 types of polio serotypes, type 1, 2, and 3. Types 2 and 3 are eradicated. So indicate whether that statement is true or it's false. So there are three types, as we have seen from the earlier presentation. But the statement is types 2 and 3 have been eradicated. So is it true that these two have been eradicated or not? So you indicate whether that statement is true or it's false. Right, so I'll give it a few seconds for the network to respond to the poll. So far, we're still less than 50% of the network has responded. So I'll give it a few more seconds for the network to respond. But so far, the tallies are that it's 50-50. Some feel the statement is true, and 50% feel the statement is false. Okay, so again, there are three types of polio. There is type 1, type 2, and 3. These are the serotypes. But is it true that the types 2 and 3 are eradicated? Indicate whether it's true or it's false. Okay, so we have a considerable number of the network that have responded to this poll question. So I'll end it in a few seconds and share the results, after which I'll allow Dr. Chipoya to just make a quick comment on the results of the poll. So I'll end the poll now and share the results. Right, so slightly above 54% say it's actually true that types 2 and 3 have been eradicated, and 46% say that it's false.
Okay, can I go ahead with the response now?
Yes, go ahead with this one.
Okay, so yes. Okay, thank you. So yes, I think the 54% are definitely correct. This statement is true. Types 2 and 3 have been eradicated, and we have type 1, 2, and 3 serotypes of poliovirus.
All right, great. Thank you, Dr. Chipoya, for that response. So we'll move on to the next poll question, which is poll question number 4, which reads, early symptoms of polio are clinically indistinguishable from flu symptoms. So you indicate whether that statement is true or false. Is it true that early symptoms of polio are clinically indistinguishable from flu symptoms, or is it indeed false? Right, so we have some responses coming in. So far, 100% say it is true that the early symptoms of polio are clinically indistinguishable from flu symptoms. Right, so I'll give it a few more seconds for the rest of the network to respond to the poll. The poll. Right, so is it true or is it false that early symptoms of polio are clinically indistinguishable from flu symptoms? Is it true or false that early symptoms of polio are clinically indistinguishable from flu symptoms? Right, okay, so we have a considerable number of the network who responded to the poll. So allow me to end the poll now and actually share the results.
Okay, so we are correct on this one. The 81% are correct on this one. Most of the early symptoms, as we had earlier said, are indistinguishable. And in addition to that, also the fact that about 75% of those that are infected also present are asymptomatic in the presentation. So that's something we also need to bear in mind.
To yet another poll question, that is poll question number 5. So poll question number 5. So poll question number 5 reads, the following are symptoms of poliovirus, except, so you indicate which of those 3 statements is the false statement. So the following are symptoms of poliovirus, except, so A, flaccid paralysis, B, fever, tiredness, headache, sore throat, vomiting, stiffness of the neck, muscle ache, and limb pain and paralysis. Then C is spastic paralysis. So indicate which of those 3 options is actually false. Is it flaccid paralysis? Is it that statement that has fever, tiredness, headache, sore throat, vomiting, neck stiffness, muscle aches, and also pains of the limb? Right, okay, so we have responses coming in from the network. The majority so far going for C, which is spastic paralysis. So we have more than 40% so far of the network that have responded to the poll. So I'll just give it a few more seconds before we can end the poll and share the results. Okay, great. So end the poll now and share the results to see which of those options is actually the exception or the false one.
Okay. Has the poll ended?
Yes.
Okay.
You can go
So the
ahead.
false one here is C, which is the spastic paralysis. What we are looking for is the flaccid paralysis, which is also called a floppy paralysis, where we have loss of muscle tone. And B, those are the symptoms, the signs and symptoms that we usually find in the mildly symptomatic cases or early on in the onset of this infection. We'll have the fever, tiredness, headache, sore throat, vomiting, neck stiffness. Yeah, mostly these are the symptoms that we will find. So false is at C.
Great, so we pause for yet another poll question. That is poll question number 6. Okay, allow me to launch the poll for the network to respond. So what is acute flaccid paralysis? So this is just a can you remember scenario, because some of this material was actually presented earlier. So we just want to see with the network if learning has taken place. So what is the definition of acute flaccid paralysis? Is it A, sudden onset of floppy paralysis in children less than 15 years due to any cause? Or is it B, sudden onset of floppy paralysis in children less than 15 years due to polio? Or is it indeed C, acute onset of spastic paralysis? I'll read that again. So what is acute flaccid paralysis? Is it sudden onset of floppy paralysis in children less than 15 years due to any cause? Or is it a sudden onset of floppy paralysis in children less than 15 years due to polio? Or is it C, acute onset of spastic paralysis? Okay, I'll go through the poll question 6 again. The question is basically just asking the definition of acute flaccid paralysis. So is it A, sudden onset of floppy paralysis in children less than 15 years due to any cause? Or is it sudden onset of floppy paralysis in children less than 15 years due to polio? Or is it acute onset of spastic paralysis? Right, so we have more than 40% of the network that have responded to the poll. So we'll just give it a few more seconds for the people in Chiengi to respond, and then we can end the poll. Okay, so far the majority going for the first option. We'll see if that is correct. All right, so we have more than 50% of the network that have responded so far. So allow me to end the poll now and share the results.
Okay, great. So what is acute flaccid paralysis? So this is the sudden onset of floppy paralysis in children less than 15 years due to any cause. So we're not looking to see which ones are polio and which ones are not, because at this point we cannot make a clinical diagnosis. Remember, the only way we will find out what the diagnosis is after we have collected samples and virology lab has given us a definite diagnosis to say this is actually due to polio. But as for acute flaccid paralysis, this is a syndrome that we find in many other diseases, like we have said earlier on. We have transient myelitis, we have GBS, and many other diseases where acute flaccid paralysis will present. Okay, so the answer there is A. So here we are, we're back to when last did Zambia have any cases of wild polio virus? So the last case of wild polio virus we had was in 2002. This was an Angolan child in the local Zambian community, which is at the border of Angola. The date of onset for the acute flaccid paralysis was on the 27th of February, 2002 in Shangombo district of Western Province. And the child had no history of immunization, meaning had not received any protection against poliovirus. Prior to that, we had a case in 1995. This was also a type 1 virus in a 6-year-old male child of Lusaka district in Lusaka province, with a date of onset of paralysis being the 30th of December, 1995. We can proceed. So this map here just shows us where exactly those cases were actually picked from. So we can see where the Northwestern province case is coming from, as well as the 2 dots where we have Lusaka province there. We can proceed. So in addition to AFP surveillance, we also have environmental surveillance, which is being conducted to complement AFP surveillance. So for environmental surveillance, the STU effluent picked up in sewer systems at the inlet of these sewer systems to help us see whether or not we have any polioviruses circulating within the community. So when this effluent is picked up, it is sent to the virology lab, and it gives us an idea after these samples are run. It gives us an idea as to whether or not there are any polioviruses in the areas that are serviced by these sewer lines. So currently we have environmental surveillance established in Lusaka and Copperbelt province, 4 sites for Lusaka and 6 in Copperbelt province. And furthermore, 1 site was recently established in Chipata due to the close proximity to Malawi, where we have this wild poliovirus currently, a wild poliovirus case in Malawi, Lilongwe. So from the ES sites that we have isolated we have not isolated any wild polioviruses or circulating vaccine-derived polioviruses. However, on 20th November 2018 in Kitwe, we isolated 1 Sabin-like type 2 virus from one of the sewer systems in that area. Okay, we can proceed. So this is just a brief background on the case that we have in Malawi. So the case is a 3-year-old female child with no history of traveling out of Malawi. So what this means is that really the child got this transmission within the country, Malawi, because the child had not traveled out, and we know that the transmission did not occur outside their home country. The child received only BOPV at birth, meaning the 0 dose, but has not received the subsequent rounds that are supposed to be given. Altogether, a fully immunized child should have 4 doses of BOPV and 1 dose of IPV. That is the address, Lilongwe, Malawi, and the date of onset of paralysis was on the 19th of November, 2021. Samples were collected on the 26th and 27th of November and sent to the lab in South Africa for sequencing, and results were received on the 16th of February, 2022. Confirming the presence of wild poliovirus in that particular child. Next slide. So this is just telling us a bit more about the sequencing that was done on this particular case, and the fact that we had 19 nucleotide changes in the virus that was picked. So this just tells us that there was differentiation that occurred in the variant that was picked from the one that was actually picked in Pakistan. So that would be like this is an orphan of that particular variant that was picked in Malawi, in Pakistan. So this means we have a period of circulation where we do not know where this virus was actually circulating. The 19 nucleotide changes is also highlighting the fact that the virus has been in circulation for approximately 2 years for those nucleotide changes to have occurred. So why are we concerned about this particular virus? Why are we concerned about having this one case? So the non-polio AFP rate, like we said, the only way for us to actually know that we do not have any poliovirus circulating in our community is to ensure that all AFP cases that are picked are, all AFP cases that are detected are investigated, and we rule out polio as the cause for the paralysis in those particular children. But from what we can see on our map here, we can see that as a country, our non-polio AFP rate has been suboptimal at subnational level. So we have not been picking those cases of acute flaccid paralysis to investigate for polio. Okay, so where we can see red, those are the districts that have been underperforming, and we can see as a region, most of the countries in the region are also at subnational level. The performance is suboptimal. This is for the years 2019 to 2021. Proportion of children that are immunized with proportion with 1 or 2 doses. From 6 to 59 months. So we can see even for our immunization, that our immunization performance is also suboptimal at subnational level. Although when we look at the national picture, it seems okay, but we have a lot of areas where we have children that are, a lot of children that are under the vaccination, that have not been vaccinated. As a country. So we can see proportion of cases with 1 or 2 doses from 2019 to 2021, we have seen a significant decline. For 2021, we can see that most of the provinces are below 20% vaccination coverage. Okay, next. So this is just the picture at for sub-Saharan, for Southern Africa, giving us our risk assessment. What is the current risk that we could have continued transmission of this virus because our children are not protected against the polio virus? So Angola here has a very high risk. We can see less than 60%. And for Zambia, we're really between 70 and 80% in terms of the vaccination coverage with BOPV. Next slide. Okay. Next. Okay, so rationale. So currently, one of the things that is being done is a multi-country response. So Zambia is amongst 5 other countries that are conducting supplementary immunization activity, enhancing surveillance, as well as strengthening routine immunization. Why has this been done? Firstly, is the immunity profile. The available administrative routine immunization data demonstrates a good coverage at national level. We've spoken about that. However, some of the district coverages have been below 80% for 2 or 3 years consecutively. The last wild poliovirus case in Malawi was in 1992, in Tanzania, 1996, but we know that despite us as the African region being declared free, any other case that may be detected will result in the rescinding of the polio-free status for the African region. Last BOPV, TOPV supplementary immunization activity in the sub-region were done at least 10 years ago. So this increases the risk that our population has. At-risk target population group is likely to include children older than 5 years because of these gaps that we have noted. We have not had supplementary immunization activities that have been conducted in over 10 years. So population movement is also very high in most of these areas. We can see that most of our borders are very porous and people move for many things, including clan linkages, trade, and economic and social reasons. So if there is transmission in one country, the likelihood that it is also going on in another country is very high. Okay, next. And this is just a summary of our epidemiology, which I believe we have gone through, so we will not reiterate. We can proceed. This is the end of our presentation. I'll pause here for any questions. Thank you, Chair.
All right, great. Thank you very much, Dr. Chipoya, for that elaborate presentation on polio, where we stand and how it actually presents. Right, so at this time, I'll open the floor to the network for any questions, clarifications, or contributions before we get some reactions from our panelists. We're joined by Dr. Dalila Zachary, and we're also joined by Dr. Bobo. Right, so I'll pause to the network for any questions, clarifications concerning the topic for today. I see there were some comments in the chat. There was one from Rose Chirwa, just inquiring about the campaign. The question is, what is the target population for the campaign? What is the target population for the campaign? So briefly, Dr. Chipoya, before other questions come in, maybe you can respond to that. What is the target population for the campaign?
So the target population is children 0 to 59 months old, which are children under 5 really, because of the increased risk of transmission in those children. So that's the target age group that we're focusing on. Thank you.
All right, great. Thank you. Thank you for that response. There was another comment, I think, from Chakiwe, requesting that maybe we can elaborate on the video. It was actually a picture of a child who had paralysis on one of the lower limbs. That was the left leg. You could see that the foot was actually plantar flexed. It was actually flaccid paralysis of the left lower limb. Just supporting the fact that in terms of symptom presentation for polio, it's usually asymmetric. compared to the other conditions that may be differentials that may present symmetrically, but it actually presents asymmetrical, and it usually affects the lower limbs compared to the upper limbs, right? And in terms of weakness, usually the proximal muscles are the ones that are usually affected compared to the distal muscles. The weakness may just involve a muscle group or the entire lower limb. So that was actually a picture that was showing a child with that weakness on the left lower limb. Right. So any other questions, concerns, colleagues on the network? There is another comment in the chat from Chimwemwe Zulu, right, and shows that it says, "Thank you for the presentation." There was a mention that a child over 5 may be at risk. Okay, like children over 5 may be at risk. So will that be considered in future after the under 5 campaign has run its course? Yes, so it's agreed that yes, children who are over 5 can also be affected. But in terms of the campaign, Dr. Chipoya, after the under 5s have been covered, is there any chance that it will be extended to those who are above that age?
Unfortunately not. Really, the target group is children under 5 years of age. Even with the analysis that are done, most of the transmissions or most of the cases that we find are actually in children below the ages of 5. So hoping that those that are above that age will have reduced risk. Of course, they are at risk, but they would have that reduced risk. So we will just focus on the children that are under 5 years of age. Dr. Bobo maybe would like to add something, but yeah, that's my response.
So great, Dr. Bobo, over to you. Would you like to add your reaction to that concerning the campaign, whether it may be extended to those above the age of 5, looking at maybe some cases that may affect those who are over the age of 5? Over to you, Dr. Bobo. Okay, we don't seem to have him. There is another comment in the chat looking at adults. How important is the polio virus in adults? Probably Dr. Dalila, are you able to take that one up? How important is the polio virus in adults?
Thank you, and thank you so much, Dr. Chipoyo, the entire EPI, ZNPHI teams for taking up this wonderful discussion during your launching of the second polio vaccine campaign here in Zambia. And thanks to the audience for being so engaging and for this question about the importance of polio virus in adults. While polio virus is, as presented by Dr. Chipoyo, primarily affects the young children, so under age 5. This is the group that of individuals that are most affected by polio virus. It can still be transmitted by adults. Remember, it's a fecal oral transmission of a virus. And this transmission, although in terms of clinical presentation, you don't see it as much in adults, can still go through a transmission cycle in adults. I'll also add, because I know this question comes up, and I know Dr. Chipoyo touched upon it in her wonderful presentation. This question around also the vaccines and polio virus. I think she talked about the oral polio virus being attenuated and being able to pass through stool once the patient has it takes the polio virus, and being able to replicate over time if there's a low vaccination rate in that community. And just to say that I was just looking at some statistics online in terms of how that risk is very, very small. So in terms of the vaccine derived polio virus, that risk it's very small compared to the public health benefit associated with oral polio vaccine virus. And in 2016, just of note, the oral polio virus actually went from trivalent to bivalent. So they removed the type 2 component. So for the past 2016? Yeah, so 6 years. It's been a bivalent virus, and the risk is very small compared to the large benefit, the hundreds of thousands of cases that have been prevented due to vaccination. So just well done all around to the government of Zambia for this campaign. Back over to you, Chair.
Great, thank you very much, Dr. Dalila, for that comment. Really, I was actually also looking at some of the issues to do with the vaccine-associated paralytic polio. As you rightly said, I think the benefit of vaccination really outweighs the risk, because some of the reports of the vaccine-associated paralytic polio is like one case in 2.5 million doses of the vaccine. So if you look at the cases, really, they're very, very, very minimal. Okay, so any other questions or comments from the network? There's some comments in the chat from Mowola Rural Health Center saying thank you for the presentation. We have been updated and we'll surely be on the lookout for those cases. Thank you for that comment, Mowola Rural Health Center. We are happy that you'll be looking out for these cases, especially after this great presentation. Back to the network, any questions, contributions? We're also joined by some of the infectious disease fellows on the call. If there are any comments from them, Dr. Chitalu Chanda, you're welcome. Dr. Kapatiso, you're welcome. Dr. Kenneth Kapolowo, you're welcome. Your comments are very much welcome. Again, questions from the network, you can raise up your hand. So I'll give it a few more minutes or seconds for the questions from the network. Before we get back to Dr. Chipoya for the last words. Okay, there's a comment from Mono Mudenda with regard to access to the presentation. This should be shared on Slack by our IT, so it will be shared on the MOH page on Slack. So you'll be able to access the presentation. All right, so it seems there are no questions in the chat and no hands raised. So I'll get back to Dr. Chipoya. Any last comments before we end? Dr. Chipoya, over to you.
Yes, thank you very much. So I think I would like to urge each and every one of us that if we could have a high index of suspicion for any cases of poliomyelitis in our health facilities, that would definitely be something that we need to do. We need to ensure that all AFP cases that we have in our facilities are actually investigated for poliovirus, for the presence of poliovirus. We can imagine that the last case we had, one of the last cases we had, which is the case in Chiengi, was actually picked in DRC and not in Zambia, and Zambia was notified of this case through WHO, meaning us as a country we're not able to detect this case. So we need to raise the index of suspicion and ensure that each case that we actually have of acute flaccid paralysis is well investigated. Stool specimens need to be collected. These stool specimens, we have 2 of them collected 24 hours apart and sent to the virology lab, which is at the University Teaching Hospital. Most of these cases that we have are actually always referred to either UTH, Levy, and Minor Soko, which are the biggest tertiary hospitals we have. So we're really relying on on our clinicians, our doctors in these health facilities to ensure that these samples are collected and sent to virology lab. Currently, we have an ongoing supplementary immunization activity, and we hope that we will definitely refer our mothers to the nearest health facilities and ensure that they also continue with the routine immunization, knowing fully well that the vaccine which is being given, BOPV, is only protecting against type 1 and 2, type 1 and 3, but they still need to receive IPV, which is protecting against the type 2 polioviruses. Thank you very much. I'll end there.
All right, thank you once again, Dr. Chipoya. Just before you go, is there any news on shortage of vaccines? I see a comment coming from Creso saying, how are we going to reach the target when we have a shortage of vaccines in almost all facilities? I don't know if you can speak to that. Is it what is obtaining, or now things have been rectified?
Thank you for that question. I know in particularly for BOPV, IPV, we do not have any shortages of those vaccines. Maybe we'll need somebody else, maybe Dr. Bobo or Dr. Monsa, if they were on the forum, to actually speak to the other vaccines, the DPTs and the rest of the other vaccines that children under 5 are expected to get. We have received adequate quantities for the BOPV that is being used for this current campaign, and it's definitely enough for the target population that is expected to receive these vaccines. Thank you.
All right, thank you, Dr. Chipoya, for that summary indeed. Thank you for coming on. Any last comments, Dr. Dalila, before we close? In summary, just the last few words.
Yes, thank you so much. Just to really thank the entire team. I think this was a great session. I think people learned quite a bit. There was a lot of discussion and questions. So just want to thank again Dr. Chipoya for really bringing all of this excellent knowledge to bear and share on the network, and for the wonderful engagement of the network for this wonderful presentation today. Thank you so much.
All right, great. Thank you, Dr. Zachary, for that. Just apologies from Professor Mlenga, who was supposed to join us as one of the panelists. He sent his apologies, couldn't join us. Right, so before we end, just an announcement that tomorrow we'll have an ad hoc echo session on smart care. Tomorrow, that is the 26th of April, 2022. It will be at 12 hours to 13 hours. So a reminder to the network to join us. This session will look at smart care plus version 1.5, and we'll specifically look at what's new and how does it make your work easier as a healthcare worker. Right, so I think I saw a hand from Dr. Kozia. Is it in line with the same ad hoc echo session for tomorrow?
No, thank you so much, Dr. Peter. No, basically, I just want to add a voice to this particular campaign that is ongoing. Knowing that children are on my heart, I think I just want to appeal to our healthcare workers out there that it's pretty important that we actually look out for acute flaccid paralysis. It's something that we take lightly, but I think in this case, I hope with this information, it will help us raise our antenna when it comes to looking out for polio. And it's important that we notify all those acute flaccid paralysis, we notify it, and so that it is tested, so that we continue to keep our active surveillance going on. And we continue to promote the children being vaccinated as well. And we just want to thank Dr. Chipoya for speaking passionately on this and educating us. Thank you so much for taking time to do that. Thank you also to the expert that came on call and to be with us this afternoon. And thank you, Dr. Matibula, a great session you facilitated for us today. Thank you very much.
All right, great. Thank you, Dr. Kozia, for that. Once again, thank you to the network for joining us, and thank you, Dr. Chipoya, Dr. Dalila, for joining us. And a reminder to all of us as healthcare workers, let's take our children for the vaccination so that we also participate in the campaign. And thank you to our coordinator, Kunda, for today, and Mutemwa, our IT support. From us at the hub at UTH, it's bye for now. We'll see you tomorrow for the ad hoc session at 12 to 13, looking at smart care. Thank you very much, and it's good afternoon for now. Bye-bye.